Patients suffering from damage in the vertebral artery and other neurological problems often present a history that seems a bit bizarre at first sight, as can the examination and the results of that examination. So to counter that, we'll spend a little bit of time talking about the signs and symptoms that can be brought on by vertebro-basilar ischemia. Now, post-traumatic damage to the vertebral artery has been well documented. This damage leads to either ischemia or hemorrhaging in the spinal cord, brainstem, cerebellum, thalamus, and/or cerebral cortex. In many instances, the damage has occurred in circumstances not normally considered traumatic. Probably the most often cited cause is therapeutic manipulation. However, most injuries seem to be spontaneous during quite unstressful activities. In these cases, there is frequently an underlying congenital anomaly that predisposes the artery to damage. The anatomy of the vertebro-basilar system is well described in texts, and there is a description in the accompanying manual. However, a short review of the anatomy is appropriate. Typically, the artery is the first branch from the subclavian. This part of the artery is called the osteo or first portion and runs in front of the 7th cervical vertebra in close proximity to the stellate ganglion. Normally, the artery enters the spinal column at the 6th cervical level in the transverse foramen. It ascends as the second or transverse portion in the transverse tunnel. At the 2nd cervical level, it becomes the 3rd or suboccipital portion and undergoes a considerable kink as it travels through the transverse foramen of the atlas and axis. It exits the Atlantean transverse foramen and winds around the back of the articular mass of the atlas, where it is constrained in a groove by a ligament. It then penetrates the posterior suboccipital membrane and the dura to become intraspinal, to reach the foramen magnum. On entering the foramen, it forms its final or 4th or intracranial portion. The two arteries run along the anterior aspect of the medulla, and at the lower border of the pons unite to form the basilar artery. This artery, after giving off a number of small and large branches, joins with the posterior communicating artery of the internal carotid to form the circle of Willis. The branches of the vertebral artery include the radicular or spinal branches that supply the nerve root and its dura, and the spinal cord. At the suboccipital level, musculo-osseous branches supply the atlas and axis, the posterior suboccipital muscles, and the dura and occipital bone around the foramen magnum. Intracranially, the largest branch of the artery is formed, the posterior inferior cerebellar artery, which is the major supply of the cerebellum. Just before the two arteries join to form the basilar, in the same area, small branches that unite to form the anterior spinal artery are given off. This artery will run down the spinal cord in the anterior median fissure and anastomose with the radicular and posterior spinal arteries. These posterior spinal arteries are given off from the posterior inferior cerebellar artery and run down the cord adjacent to the posterior roots. Small medullary branches arise from the arteries as they pass over the medulla and supply this structure. The basilar artery gives rise to pontine branches which supply the pons, an anterior, inferior and superior cerebellar artery, a labyrinthine or internal auditory artery, and two cortical branches, the occipital and temporal, which supply the thalamus, visual cortex and speech areas of the temporal lobe. A central branch also supplies the thalamus. From the areas it supplies, it can be seen that the vertebro-basilar system is responsible for spinal cord and root function via its spinal and radicular arteries, cerebellar and reticular function, cranial nerve activity, speech and vision, and thalamic function. The signs and symptoms of vertebro-basilar ischemia and bleeding are relatively simple exercises in neuroanatomy. The above anatomy is an overall average. In fact, anomalies somewhere in the system is the norm. Beginning with the first portion, the most common variant is the right artery arising from the aorta in about 4% of the population. It is speculated that the higher pressures this subjects the artery to may predispose it to damage later in life. In the second portion, the entry point into the spinal column may vary. The usual entry into cervical 6 occurs 90% of the time, but the entry point might be anywhere from C7 to C3 and even as high as C2. The higher the entry point, the more the artery is subjected to torsional forces. The number of radicular branches may vary. Rarely there is one at each level. More commonly, there are 3 or 4 on each side. The less arteries there are, the larger they are, so that the variable area of the spinal cord is dependent on a watershed effect of the extant arteries. Intracranial variations include various different origins for the branches. Occasionally, the posterior inferior cerebellar artery arises from the vertebral artery at the medullary level, and the labyrinthine artery normally arises from the anterior inferior cerebellar, but in about 16% of subjects comes off the basilar directly. Probably for us, the most significant variant is the side-to-side diameter of the arteries. In only 40% of the population are they approximately equal. In the other 60%, there are significant inequalities in size. Sometimes the smaller or minor artery is insignificant and termed hypoplastic. Occasionally, one artery does not inject into the basilar but terminates as the posterior inferior cerebellar artery. These are termed atretic. Occasionally, one or both arteries are absent. These more extreme variations will presumably leave the subject less able to withstand damage or disease processes affecting the normal artery due to the insufficiency of the backup system. From the anatomy and supply areas of this vascular system, the tissues affected and the effects caused by ischemia can be understood. The osteal portion does not directly supply any structure and so in itself cannot produce symptoms. However, if it is compromised, it of course can reduce the blood flow onwards. Occlusion of this part of the artery is rare and is generally caused by atherosclerosis, penetrating trauma, sympathetic nerve compression, thoracic outlet syndrome, post-surgical scarring, tumours of the apex of the lung and fibromuscular compression. The transverse portion is more commonly affected and in addition to reducing cranial flow has direct effects. These include spinal cord, nerve root and dural signs and symptoms. Documented causes of ischemia here include atherosclerosis, sympathetic irritation, osteophytosis, disc herniation, paravertebral tumours, blunt trauma, segmental instability and subluxation, fibrous band compression, embolism, spinal stenosis and arteriovenous fistulae. The suboccipital portion is perhaps the most commonly affected. Direct effects may include severe suboccipital headaches, spinal cord signs and symptoms and radicular root pain. This portion of the artery is very superficial as it passes over the arch of Atlas and is susceptible to blunt and penetrating trauma. In addition, its course through the transverse foraminae of C1 and 2 is very tortuous, and here the artery is subject to blunt internal trauma from atlanto-occipital and atlantoaxial subluxation and instability, second nerve entrapment, arteriovenous fistulae, and prolonged iatrogenic positioning for dental or surgical work. Additionally, congenital deformities such as Klippel-Foul syndrome and basilar invagination may cause or be contributive. In addition to these problems, the usual atherosclerosis, embolism and fibrous band compression may affect this part of the artery. The intracranial parts produce symptoms post-traumatically by a compromised lower down, although brainstem pinpoint hemorrhaging appears to be common after head and neck trauma. Signs and symptoms from intracranial ischemia can include spinal cord signs and symptoms via the spinal arteries, cranial nuclei deficit, spinothalamic, corticobulbar, reticular, ambigus and long cord signs. Brainstem syndromes include lateral, medial and dorsolateral medullary syndromes, Horner's syndrome, middle pons syndrome, Foveal and Millard-Gubler syndrome. Midbrain lesions may cause Weber's, Benedict's and Parinode syndromes. It is extremely unlikely that the manual therapist will see any of these syndromes in the full-blown phase. However, depending on the degree of ischemia, a greater or lesser number of signs and symptoms belonging to them may be in evidence. In general, unilateral ischemia of the medial part of the brainstem will mainly affect the corticospinal tract, medial lemniscus and hypoglossal nucleus. This will produce contralateral hemiparesis with sensation and proprioception decrease and reduced tongue control resulting in lingual deviation on protrusion. Unilateral ischemia of the lateral brainstem will affect the lateral spinothalamic tract, spinocerebellar tracts, the nucleus ambiguus, solitarius, trigeminal and vestibulocochlear nuclei, and the descending sympathetic fibres of the reticular formation. Again, depending on the degree of ischemia, the following signs and symptoms might be found. Contralateral body and limb pain with temporal sensation decrease, ataxia, ipsilateral Horner's syndrome, ipsilateral facial sensation loss with nystagmus, hypoacusia, tinnitus and dizziness. Other cranial nerves may be affected depending on the size of the lesion. In all unilateral brainstem lesions, the cranial nerve signs and symptoms are ipsilateral and body signs and symptoms contralateral. In the majority of cases seen by the manual therapist post-trauma, only relatively minor isolated signs and symptoms will be discerned, but these will normally be in a similar though reduced distribution of the full-blown syndrome. It is not the therapist's job to diagnose the exact location and size of the lesion, but it is his or her role to recognise these central nervous system signs and symptoms and alert the physician to their potential seriousness. This video will demonstrate a graduated examination of the post-traumatic patient that has the potential for identifying the more serious signs and symptoms of the neck trauma patient, without demanding that the therapist be an expert in neuroanatomy or neurotherapy.